Thank you for inviting me to speak at the Immunology Allergy Conclave about insect venom allergy and mast cell disorders. My name is Adriana and I'm Head of Immunology Allergy at the Royal Hobart Hospital in Tasmania, Australia. Our centre specialises in insect allergy, specifically jack jumper ant allergy, which is the leading cause of anaphylaxis in our part of Australia, but we also manage honeybee and wasp allergy, which are prevalent worldwide. Today I'll be talking about stinging insect allergy in relation to mast cell disorders. This is an overview of my talk and the abbreviations that will be commonly used throughout the talk. I plan to start with a discussion of Hymenoptera venom allergy in general, followed by a general overview of mastocytosis and clonal mast cell disorders. Then that will follow on to an overview of a more recently recognised mast cell condition, hereditary alpha tryptocemia. This will follow on to a discussion on the approach to evaluating patients with Hymenoptera venom allergy for mast cell disorders, as well as some of the issues with diagnosing Hymenoptera venom allergy in patients with clonal mast cell disorders. Finally, the talk will end with a discussion of management of patients with Hymenoptera venom allergy and clonal mast cell disorders. This figure on the right shows an overview of the order Hymenoptera, or stinging insects. Stinging insects of most relevance in allergy are, as we know, bees, wasps, hornets and ants. Insect allergy is a leading cause of anaphylaxis globally and the most frequent cause of anaphylaxis of adults in Europe. It is estimated that the lifetime sting prevalence ranges between 55 and 95% of people experiencing a sting in their lifetime, with up to 9% of people experiencing a systemic allergic reaction to an insect in their lifetime. That said, while there is a high rate of sensitization to Hymenoptera venom allergy in the general population, estimated to be up to 25%, most of these patients will not develop systemic allergic reactions to insect stings, despite having positive results on venom-specific IgE or skin testing. This figure shows some of the insects of most relevance in venom allergy. And these figures show where these insects can be found globally. As you can see, honeybees have been cultivated almost everywhere, while wasps are also widespread, found in Europe, Asia, America and Australia. Vespula vulgaris, also known as the yellow jacket wasps, are especially common in Europe and Asia, as are hornets, while Solenopsis species or fire ants are native to South America, but due to globalization have become established in North America and now becoming increasingly reported further afield. Manish pilosula or jack jumper ants are only found in Australia, but here they are a leading cause of insect anaphylaxis in the southeastern regions of Australia. So when we see patients with suspected insect allergy, they generally referred to us because of either excessive large local or immediate systemic allergic reactions to insect stings. Large local reactions in themselves are not dangerous, except in the very rare circumstance when stung inside the throat or mouth, in which case swelling may cause airway obstruction. The nature of a patient's insect allergy is established through the history, as currently available routine tests are not able to distinguish routine asymptomatic sensitization, large local reactions and systemic reactions. The rest of this talk is focused on patients with a history of immediate systemic reactions rather than local allergic reactions. And when I use the term Hymenoptera venom or insect sting allergy, I'm referring to patients with a history of immediate systemic reactions or anaphylaxis. The figure on the right shows the range of manifestations in immediate systemic reactions or anaphylaxis, and it should be noted that an absence or less prominence of skin symptoms is not uncommon in insect anaphylaxis, so a high index of suspicion may be required, especially in patients who present with collapse or cardiac symptoms after a sting. Kuhne's syndrome specifically refers to the development of acute coronary syndrome due to anaphylaxis and presents with the findings of an acute coronary syndrome like chest pain, ECG changes and troponin elevations, but then these patients go on to have normal coronary angiograms and may have elevated tryptases during the episodes. Patients who have had an immediate systemic reaction have an increased risk of recurrent systemic reactions with future stings, ranging from 30 to 70% depending on the insect type and severity and time lapsed since the index systemic reaction, while children with immediate systemic reactions limited the skin are thought to be at low risk of future systemic reactions. Conversely, it is thought that patients with mastocytosis have an increased risk of systemic reactions compared to patients without mastocytosis, more of which I will go into later. In patients with only large local reactions to insect stings, the risk of a future systemic reaction to insect stings is generally considered to be low. Collectively, the evidence from 1980 to 2018 suggests that systemic reaction risk may be as low as 3%. However, one recent prospective study did suggest systemic reactions can occur in up to 25% of patients who have a history of only a single large local reaction, while this risk was lower if there was a history of multiple large local reactions. For patients who do present with immediate systemic reactions to insect stings, it's important to establish the severity of the reaction. So this slide shows some of the different grading systems for anaphylaxis. A lot of insect allergy papers use Mueller grading, which makes sense as it was originally developed to grade insect allergies specifically. Our centre and quite a lot of other groups also use the Brown grading system, which was more recently developed by a Tasmanian Australian, actually. Professor Simon Brown in the early 2000s developed this as a simpler and more intuitive way of grading anaphylaxis with only 3 grades. Professor Brown was one of the main investigators to develop Jack-John-Paran venom immunotherapy, but he also developed this grading system based on anaphylaxis presentations to ED of all causes, and used logistic regression analyses of associations between individual reaction features and hypotension and hypoxia to construct this grading system. So grade 1 is cutaneous symptoms only. Grade 3 is severe manifestations of anaphylaxis, including objective hypotension, cyanosis, desaturation, impaired consciousness or incontinence, while grade 2 is everything in between. The studies referenced in the rest of this talk mainly use Mueller or Brown grading. So why does insect allergy matter? On the one hand, fatalities due to anaphylaxis are rare, as can be seen from this figure, where the annual incidence of fatal venom anaphylaxis is comparable to death by lightning. While this is in an unselected population, even in patients with known insect allergy, fatal anaphylaxis constitutes less than 1% of their mortality risk. However, even if the absolute mortality risk is low, there's a significant morbidity associated with insect allergy in terms of adversely impacting quality of life, which is not relieved by and perhaps even exacerbated by having to carry EpiPens or other adrenaline autoinjectors. It is also likely that fatalities due to insect allergy are underestimated. It's known that the majority of insect anaphylaxis deaths are due to cardiovascular collapse and in middle age to older men. So the deaths may be attributed to other causes such as myocardial infarction, especially in the absence of visible skin symptoms. In addition, insect anaphylaxis disproportionately affects rural populations, so fatal anaphylaxis stings are more likely to be unwitnessed. Around half of people who die from insect anaphylaxis don't have a preceding history of insect allergy. So again, it's easy to miss this diagnosis since the index of suspicion will be less in these people. And anaphylaxis is also difficult to diagnose on autopsy, especially when the mechanism is cardiovascular collapse. In such cases, even with a pre-test probability for death by anaphylaxis of nearly 100%, the sensitivity of autopsy may be less than 50%. And so that's why it may be difficult to ultimately confirm the cause of death in Sanjay Kapoor, who is pictured here and who you may recognise as an Indian billionaire who died in June this year after collapsing during a polo match. The media reported he died suddenly after being stung in the mouth by a throat or bee with collapse shortly after. So it is presumed that his death was due to bee sting anaphylaxis. This figure shows generally accepted risk factors for more severe systemic reactions on the left, while the right column shows variables that have been shown not to be risk factors for severe systemic reactions to stings after all. An elevated baseline tryptase level is a very well established risk factor for severe systemic reactions to stings, and a basal tryptase of more than 11.4 is shown to correlate with around a 2.5-fold increased risk for severe systemic reactions to stings. An absence of skin symptoms in sting-induced anaphylaxis is known to be an indicator of severe anaphylactic reactions, with an association with loss of consciousness and cardiopulmonary symptoms, and often associated with an underlying clonal mast cell disorder. It should be noted that baseline tryptase is often normal in patients with mast cell disorders, but that clonal mast cell disorders are still a risk factor for more severe systemic reaction to stings, even in the presence of a normal baseline tryptase. So mastocytosis or clonal mast cell disorders actually encompass a heterogeneous group of diseases, all characterized by an increased accumulation and clonal proliferation of mast cells in the skin, bone marrow, or other organs. It's an uncommon disorder with an estimated prevalence of 1 in 10,000. It was first described as a cutaneous condition in 1869, but the systemic form was not described until 1949. While its clonal origin was established in 1995 as an activating mutation in the KIT gene, which encoded for the stem cell receptor, also known as CD117. Activation of the KIT receptor is normally ligand dependent, but is in patients with mastocytosis, there is constitutive and continual activation of KIT, leading to uncontrolled proliferation, maturation, and survival of mast cells, and in some cases, excessive mast cell degranulation and mast cell mediator release with associated symptoms. Following identification of the causative KIT mutation, the aberrant expression of various markers, including CD25, CD2, and CD30, have been identified and found to assist in the pathological diagnosis of mastocytosis. Over the past 30 years, there has been advancement in the classification systems for this disease, which were updated by the WHO and the ICC in 2022. The distinction between cutaneous mastocytosis, which mainly affects children and is limited to the skin, and systemic mastocytosis based on extracutaneous manifestations remains valid. Systemic mastocytosis is a pathological diagnosis made if one major and one minor criterion or 3 minor criteria are met on extracutaneous biopsy specimens, preferably bone marrow. While elevated baseline tryptase is one of the minor criterion, up to 69% of patients with mastocytosis can have normal baseline tryptases below 11.4. This has led some to suggest that a baseline tryptase of more than 20 should be removed from the criteria or needs to be updated to incorporate tryptase genotyping, which I'll talk about later. If a patient does meet criteria for systemic mastocytosis, it is then further characterized into non-advanced systemic mastocytosis subtypes, which consist of indolent systemic mastocytosis, isolated bone marrow mastocytosis, and smoldering systemic mastocytosis, and advanced systemic mastocytosis subtypes, which include systemic mastocytosis with associated hematopoietic neoplasms, aggressive systemic mastocytosis, and mast cell leukemia. Distinguishing between non-advanced and advanced systemic mastocytosis is generally based on the presence of B or C findings, and more recently, high variant allele frequency of the KIT PD816V mutations of 10% or greater have been recognised as a novel B finding. Indolent systemic mastocytosis is the most prevalent mastocytosis subtype, and 30% of patients previously classified as having ISM are now classified as having a subvariant known as bone marrow mastocytosis. Bone marrow mastocytosis is a relatively new non-advanced systemic mastocytosis subtype and is characterized by a low neoplastic mast cell disease burden and absence of skin disease, and often with baseline tryptase levels of less than 11.4. Some patients may have such a low level of neoplastic mast cell burden in the bone marrow that the WHO criteria for mastocytosis is only met partially. In these cases, the diagnosis is monoclonal mast cell activation syndrome. Indolent systemic mastocytosis, bone marrow mastocytosis, and monoclonal mast cell activation syndrome are the subtypes most likely to be associated with insect sting allergy. These forms of mastocytosis are usually associated with a low mast cell burden, fewer symptoms associated with release of mast cell mediators between acute episodes, and normal baseline tryptase levels. Conversely, very high baseline tryptase levels in systemic mastocytosis are paradoxically less likely to be associated with Hymenoptera venom allergy. While systemic mastocytosis is rare, Hymenoptera venom allergy is common in systemic mastocytosis patients. It's estimated that over half of patients diagnosed with mastocytosis will report anaphylaxis, with insect stings and idiopathic anaphylaxis identified as the most common causes of anaphylaxis in these patients. Overall, patients with systemic mastocytosis have a significantly higher frequency of Hymenoptera venom allergy, of around 20% compared to less than 1% in the general population, and the rate of Hymenoptera venom allergy may be as high as 50% in those with bone marrow mastocytosis. Similarly, mastocytosis is disproportionately represented in patients with Hymenoptera venom allergy, with clonal mast cell disorders found in 8% of these patients by one estimate. Mastocytosis is associated not just with an increased frequency of Hymenoptera venom allergy, but also increased severity of reactions. Studies have shown that individuals with severe grades of Hymenoptera venom allergy, 20 to 34% of these patients were tested positive for KIT P.D816V mutation on blood, while the KIT mutation rate was significantly lower in patients presenting with lower grades of Hymenoptera venom allergy. I would now like to talk a bit about hereditary alpha tryptocemia, which is a more recently recognised condition compared to mastocytosis, but which may have a significant impact on the workup of insect allergy patients for mast cell disorders. As we know, tryptase is a serine protease generated by tissue-resident mast cells. It is present in 4 isoforms, 2 of which are biologically relevant, alpha and beta. As you can see from this figure, the human tryptase locus is found on chromosome 16. The TPSAB1 gene codes for alpha tryptase and beta tryptase, while the TPSB2 gene codes for beta tryptase. A normal genotype consists of 4 TPSAB1 and TPSB2 copies, of which 2 to 4 are beta tryptase copies. Hereditary alpha tryptocemia occurs when there is an increase in TPSAB1 gene copy numbers, encoding for alpha tryptase such that there are 5 or more TPSAB1, TPSB2 copies, 2 or more of which are alpha tryptase copies. This slide shows 3 different laboratory techniques which can be used to perform tryptase genotyping, namely Sanger sequencing, Southern blotting, and droplet digital PCR. Depending on the lab, this may be performed on blood or saliva samples. A potential limitation is that only a small number of laboratories perform tryptase genotyping. In Australia, tryptase genotyping only became locally available this year, and even then it is only performed in 1 laboratory in the country. That said, patient samples can also be sent internationally to commercial labs, which may not be that onerous, especially with salivary samples. An example of a lab report for tryptase genotyping is also shown here. Studies have shown that hereditary alpha tryptocemia is common, present in around 5% of the population, and therefore the most common cause of an elevated baseline tryptase, far exceeding clonal mast cell disorders and advanced chronic kidney disease as a cause for an elevated tryptase. Most patients with hereditary alpha tryptocemia only have 1 extra copy number of alpha tryptase, but up to 10 extra copies have been reported. Patients with 1 extra copy number have a median baseline tryptase of 14, and each extra copy adds approximately 10 micrograms per ml to the basal tryptase. The table in this slide shows baseline tryptases and the predicted upper limit of baseline tryptases by number of extra alpha tryptase copies. Hereditary alpha tryptasemia is sometimes observed in individuals with a high normal baseline tryptase between 8 and 11. It's rare for individuals with hereditary alpha tryptasemia to have a baseline tryptase less than 8, and tryptase genotyping shouldn't be performed when a baseline tryptase is less than 6, as there have not been any cases of hereditary alpha tryptasemia observed at those levels. So does having hereditary alpha tryptasemia matter in patients with Hymenoptera venom allergy? The studies to date would suggest yes. This table summarises 2 large cohort studies of patients with Hymenoptera venom allergy where HAT was identified with higher frequency in patients with higher grade anaphylaxis, while the frequency of HAT in lower grade anaphylaxis was similar to the background frequency found in the general population. As a result, while HAT is not necessarily associated with an increased risk of developing insect allergy overall, it does appear to potentially modify the clinical outcome and be associated with an increased severity of sting reactions. If this is the case, the long-standing association between an elevated baseline tryptase and more severe Hymenoptera venom allergy, even in the absence of systemic mastocytosis, may be accounted for by HAT. So we know that clonal mast cell disorders and HAT are more prevalent in patients with Hymenoptera venom allergy and may have important disease-modifying effects. I would now like to talk about how to evaluate a Hymenoptera venom allergy patient for a mast cell disorder. This figure shows a recent suggested approach by Gonzalez del Llanos group, recently published in JACI in Practice, which I'll now go through. You will already have done the usual workup, taking a history to confirm that this patient has a history consistent with Hymenoptera venom allergy, and confirm the relevant sensitization on routine diagnostic with testing with specific IgE testing or venom skin testing. So what next? Well, physical examination, it turns out, is still important. There are 3 forms of cutaneous involvement in mastocytosis: maculopapular cutaneous mastocytosis, which was formerly known as urticaria pigmentosa, diffuse cutaneous mastocytosis, and mastocytoma. Maculopapular cutaneous mastocytosis can be either divided into monomorphic and polymorphic forms. Monomorphic maculopapular cutaneous mastocytosis is associated with small uniform lesions distributed on sun-shielded areas of the skin, while the polymorphic form is associated with large, variably sized macules and papules and can occur on sun-exposed areas, including the hairline and scalp. Most adults will have monomorphic macular maculopapular cutaneous mastocytosis, whereas children typically have the polymorphic form, which typically resolves spontaneously in adolescence. Unlike in children where cutaneous mastocytosis is not usually associated with systemic involvement, the majority of patients with adult onset skin lesions will have systemic mastocytosis. For example, in one study of 59 patients with adult onset skin lesions typical for mastocytosis, 97% ended up having systemic mastocytosis. While the majority of patients with Hymenoptera venom allergy and systemic mastocytosis will not have any skin lesions, the finding of monomorphic maculopapular cutaneous mastocytosis has been found to be highly specific for indolent systemic mastocytosis in adults. Therefore, if it is found in a patient with Hymenoptera venom allergy, the recommendation is that the patient should be considered for bone marrow biopsy for investigation for systemic mastocytosis, regardless of the other clinical features or tryptase level. However, the majority of patients with Hymenoptera venom allergy will not have any suggestive skin lesions, and in these patients it's proposed that the REMA score and the baseline tryptase should be used to risk stratify patients for the likelihood of an underlying clonal mast cell disorder. REMA stands for the Red Espanola de Mastocytosis score, developed by the Spanish Network of Mastocytosis. In its initial validation, a score of 2 or higher had a reported specificity of 81% and a sensitivity of 92% for mastocytosis when considering only patients presenting with anaphylaxis. Features of anaphylaxis that were established as having a high risk for having systemic mastocytosis included syncope, presyncope, the absence of urticarian angioedema, male sex, and a baseline tryptase of more than 25. The hazard ratio was highest for syncope and matches the cardiovascular collapse frequently seen in patients with mastocytosis and anaphylaxis to insect venom. While the initial validation of this score revealed both a high sensitivity of 91% and a high specificity of 75%, the application of the REMA score in a large venom allergic population was lacking, but a recently published multi-center study found that the REMA score achieved a sensitivity of only 70%, suggesting that some cases of clonal mast cell disorders will still be missed using just this approach. Furthermore, using REMA alone also doesn't take into account the patient's tryptase genotype. Studies have supported that patients with a baseline tryptase value that's higher than predicted for their tryptase genotype are at risk of systemic mastocytosis with a sensitivity of 84% and a specificity of 90%. This specificity increases to 97% when combining it with a REMA score of 2 or more. As a result, it has been recommended that, if possible, the evaluation of patients with Hymenoptera venom allergy for mast cell disorders should include screening for a discordant tryptase genotype, and that these patients should be considered for bone marrow biopsy even if their REMA score is less than 2. A fourth approach to screening for systemic mastocytosis in patients with Hymenoptera venom allergy is testing all patients with a severe anaphylaxis grade, that is Mueller grades 3 and 4 or Brown grade 3, for KIT PD816V mutation testing by high-sensitive PCR techniques on blood. The assay used is critical, and preferred methods are high-sensitivity quantitative methods such as digital droplet PCR and allele-specific PCR, rather than low-sensitivity methods such as Sanger or next-generation sequencing. Peripheral blood leukocyte enrichment techniques versus just testing on whole blood also increases sensitivity significantly. However, these assays and techniques are not yet widely available, so even though a high sensitivity assay can detect KIT PD816V in patients with a low burden of disease and lower baseline tryptase levels who would otherwise be missed, the techniques are unfortunately not always accessible. Patients with Hymenoptera venom allergy and mastocytosis usually have non-advanced systemic mastocytosis, which typically only have a moderately increased KIT D816 variant allele frequency levels of 0.02% to 1%, compared to variant allele frequency levels of more than 1% in advanced mastocytosis subtypes. It should also be noted that while quantitative assays have allowed for high sensitivity with blood testing, in 30% of patients with KIT PD816V positive bone marrow mastocytosis, the KIT mutation is detectable in only bone marrow, but not blood. Presuming you do have access to high sensitivity testing for KIT D816V testing, it should be considered in patients with severe Hymenoptera venom allergy, even with a normal baseline tryptase. Selb et al. Prospectively recruited 374 patients with Hymenoptera venom allergy and no overt signs of mastocytosis, performing high sensitivity KIT PD816V testing on peripheral blood as well as tryptase genotyping in all patients. The KIT PD816V was detected in 8% of patients, many of whom had normal baseline tryptase levels, and was predominantly found in patients with Mueller grade 4 anaphylaxis, occurring in 18.2% of grade 4 patients versus 1.8% in grade 3 and 0% in lower grades. In grade 4 patients with a normal baseline tryptase, KIT PD816V positivity was associated with more severe symptoms, including a significantly higher frequency of loss of consciousness and absence of skin symptoms. Amongst patients with a normal baseline tryptase, KIT PD816V was the major risk factor associated with severe Hymenoptera venom allergy. In the 6% of patients with an elevated tryptase in this study, HAT was the most common cause. So the authors of this study concluded that routine KIT PD816V screening identifies clonal disease in high-risk patients, regularly missed using just baseline tryptase alone. Another study of patients with Hymenoptera venom allergy treated with venom immunotherapy found 34% of patients had a detectable KIT PD816V in peripheral blood. However, while such testing seems to show promise, in these studies the specificity of this test was unknown, and nearly all patients who had a confirmatory bone marrow biopsy also had an elevated REMA score, monomorphic cutaneous mastocytosis, or a discordant tryptase genotype, so may have been picked up anyway with the other proposed approaches. The gold standard for the diagnosis of mastocytosis remains bone marrow biopsy, which relies on immunohistochemical staining and KIT PD816V PCR testing to demonstrate the major and minor criteria of systemic mastocytosis. In more detail, immunohistochemical staining with mast cell-specific antibodies to anti-tryptase and anti-CD117 is used to assess the degree of bone marrow infiltration by mast cells as well as mast cell morphology. Most patients with mastocytosis will have mast cells that aberrantly express CD25, whereas a smaller number of patients will also have mast cells that aberrantly express CD2 or CD30. Ideally, bone marrow biopsies should be analysed at a centre of excellence, as immunohistochemistry errors are common. For example, in one study, immunohistochemistry errors occurred in 25% of patients diagnosed with mastocytosis. Immunohistochemistry problems included absent CD25 and tryptase test ordering, CD25 immunohistochemistry methodology errors, and hematopathologist interpretive errors when assessing the major and minor criteria. As a result, if your laboratory has limited experience with mastocytosis biopsies, and if there's a high index of suspicion, it may be worth asking them to forward the specimen to a centre of excellence for a second opinion. I would now like to pivot a bit with an aside on diagnostic testing for Hymenoptera venom allergy in patients with clonal mast cell disorders. The diagnosis of Hymenoptera venom allergy in patients with clonal mast cell disorders can be challenging, as it is well known that patients with mastocytosis have lower levels of total IgE as well as specific IgE. This is hypothesized to be due to the absorption of IgE to the surface of the expanded mast cell population. As a result, it is proposed that a lower cutoff level of venom-specific IgE of 0.1 rather than 0.35 be used in these patients. And it should be noted that venom intradermal skin testing is considered to be safe in systemic mastocytosis patients, although both specific IgE and venom skin testing should be deferred at least 2 weeks after a sting to reduce the likelihood of false negative results. Double negative results, which is the situation of having both a negative specific IgE and venom skin test despite a good history for Hymenoptera venom allergy, is more common in mastocytosis patients compared to patients without mastocytosis. In these patients, testing can be repeated 6 weeks to 6 months later. Basophil activation testing to the suspected venom has also been shown to be useful in confirming sensitization in double negative patients with mastocytosis, but it's not routinely available in most centres. Another issue I'd like to touch on is the question of whether Hymenoptera venom sensitization should be assessed in patients with clonal mast cell disorders without a history of Hymenoptera venom anaphylaxis. There is only one major study addressing this question, a 2017 study which assessed 243 adults with indolent systemic mastocytosis seen over a 30-year period at a specialist referral centre in the Netherlands where yellow jacket allergy is prevalent. In this cohort, 63% of patients reported at least one yellow jacket sting in adulthood. 54.2% of these patients in turn reported having at least one systemic allergic reaction to a yellow jacket sting. It was noted that indolent systemic mastocytosis reactors had significantly lower yellow jacket venom-specific IgE levels compared to non-mastocytosis reactors, but that asymptomatic sensitization was exceedingly rare. The first systemic reaction in this ISM cohort was severe in the majority, as in 70% of patients, and systemic reactions occurred in 97.5% of patients, of which 90.6% of reactions were severe. This centre also had a fatality in an ISM patient who had previously only had a history of local reaction to yellow jacket stings, but then had a catastrophic anaphylaxis to yellow jacket sting. The study findings led the authors to conclude that venom-specific IgE screening should be performed in all patients with indolent systemic mastocytosis, and that at least in this population, venom immunotherapy should be considered in all patients with ISM and a yellow jacket specific IgE of more than 0.17. I'm now going to finish off the talk with talking about management of Hymenoptera venom allergy in patients with clonal mast cell disorders. While we're all very familiar with prescribing adrenaline autoinjectors to patients with Hymenoptera venom allergy, given there is a potential for more severe refractory anaphylaxis in mastocytosis patients, consideration should be made to prescribing these patients multiple autoinjector devices. In Australia, all adult patients assessed by an immunologist as being at risk of anaphylaxis can be routinely authorised for 2 or more autoinjectors via the nation's pharmaceutical benefit scheme, but some guidelines for Hymenoptera venom allergy even suggest prescribing 3 devices if their patients have mastocytosis. Some patients may also be reluctant to seek emergency medical attention after using an adrenaline autoinjector, but Hymenoptera venom allergy patients with mastocytosis should be counselled on the importance of seeking further medical attention in case more advanced anaphylaxis management is required. And given the predominant mechanism of fatality in Hymenoptera venom anaphylaxis is cardiovascular collapse, which is even more pronounced in patients with mastocytosis, patients should be counselled also on the importance of recumbent positioning and avoiding standing. However, the definitive treatment for Hymenoptera venom allergy in clonal mast cell disorders is the same as patients without clonal mast cell disorders, that is venom immunotherapy. While there has previously been some reticence about desensitizing Hymenoptera venom allergy mastocytosis patients due to concerns about the safety of the procedure in these patients, It is arguable that these are the patients who need the venom immunotherapy treatment the most, as they are at increased risk of severe and life-threatening anaphylaxis. This table shows the efficacy and treatment side effect rates of available venom immunotherapies in adult patients with Hymenoptera venom allergy. It can be seen that without venom immunotherapy, Hymenoptera venom allergy allergic patients have a 25 to 70% risk of recurrent systemic reaction with their next sting, and that many of these systemic reactions will be severe. In contrast, the risk of systemic reaction to stings falls to less than 20%, and in many cases less than 5 to 10% in patients who undertake venom immunotherapy. While systemic reactions to venom immunotherapy can be common, affecting 10 to 40% of patients, the majority of these reactions are mild and only occurred during updosing. So with that overview of the efficacy and safety of venom immunotherapy in general Hymenoptera venom allergy patients, how does that compare to the efficacy of venom immunotherapy in patients with mastocytosis? The table here shows a summary of the literature addressing the question of effectiveness of venom immunotherapy in mastocytosis, with the efficacy varying widely from 15 to 85% depending on the study. The largest study reported by Bonadonna is of 84 patients with indolent systemic mastocytosis and Hymenoptera venom allergy who underwent venom immunotherapy. 81% of patients initially presented with anaphylaxis after an insect sting, and 63% had loss of consciousness at the time of the reaction. Patients were variously diagnosed with honeybee, yellow jacket, and paper wasp allergy and underwent the relevant venom immunotherapy. Systemic reactions during build-up venom immunotherapy were uncommon, and no patients required adrenaline or hospitalization for systemic reactions to venom immunotherapy. 51 patients had 95 stings after the initiation of immunotherapy, and 86% were fully protected. Looking at all studies, the overall efficacy of venom immunotherapy is estimated to be around 72% in mastocytosis patients, which is lower than patients without mastocytosis, but certainly still high enough to warrant offering venom immunotherapy to these patients. So what is the safety and tolerability of venom immunotherapy in patients with mastocytosis? As just mentioned, Bonadonna's study showed favourable safety and tolerability of venom immunotherapy in indolent systemic mastocytosis patients. These tables expand on this further, showing reported rates of systemic reactions to venom immunotherapy in mastocytosis patients in the top table versus systemic reactions to venom immunotherapy in a general population. Overall results suggest venom immunotherapy systemic reactions are probably more frequent in mastocytosis patients, especially in patients with yellow jacket allergy. With systemic reactions to yellow jacket venom immunotherapy occurring in 35% of mastocytosis patients versus 11% rate in general patients, and systemic reactions to honeybee venom immunotherapy occurring in 38% of mastocytosis patients versus 27% in general patients. It should also be noted that while earlier studies suggested systemic reactions were higher in ultra-rush or rush protocols compared to slower updosing protocols in mastocytosis patients, more recent studies have reported good tolerability of ultra-rush and rush protocol in mastocytosis patients. And certainly this has been our experience in our own centre, where we are quite comfortable starting patients with mastocytosis with honeybee or wasp allergy on rush or ultra-rush protocols. On a related note, studies suggest that overall there is only a slightly increased risk of systemic reactions to venom immunotherapy in patients with an elevated baseline tryptase, at least when analysing honeybee and yellow jacket venom immunotherapy patients as a combined group. However, there does seem to be an elevated risk of systemic reactions to venom immunotherapy in patients with an elevated baseline tryptase when analysing patients receiving just yellow jacket wasp venom immunotherapy, whereas studies did not identify an elevated risk of systemic reactions to venom immunotherapy in honeybee VIT patients, specifically with an elevated tryptase. So what does this translate to in clinical practice? While venom immunotherapy may have slightly lower success rates in mastocytosis patients, they should still be offered VIT as they stand to benefit the most if treatment is successful, and VIT is still well tolerated in the majority of these patients. If patients are successfully established on VIT, treatment should be continued lifelong or as long as there is significant risk of insect sting exposure, as there are case reports of sting fatalities in venom allergic mastocytosis patients after stopping VIT. Systemic reactions to VIT may be more frequent and severe in these patients, and while more frequent during build-up, can also occur during maintenance venom immunotherapy. As a result, additional precautions may be considered in these patients, such as cannulation or treating in a hospital rather than outpatient setting, especially during the updosing phase. It has been noted that up to 25% of patients with mastocytosis and Hymenoptera venom allergy are not fully protected with standard maintenance doses of venom immunotherapy. And patients with systemic reactions to field stings or sting challenges on maintenance venom immunotherapy treatment should have their maintenance venom immunotherapy dose increase, as this has been shown to be effective. In patients not tolerating venom immunotherapy due to systemic reactions to the immunotherapy injections, consideration should be made for pre-medication with an anti-IgE monoclonal antibody omalizumab and increasing the maintenance dose. Most of the literature concerning use of omalizumab to manage VIT-related allergic side effects relates to patients having difficulty tolerating honeybee venom immunotherapy, while there are also a few reports of omalizumab being successfully used to help patients tolerate wasp venom immunotherapy. This table summarises the current literature assessing omalizumab use in honeybee venom immunotherapy. As you can see, many of these patients had systemic mastocytosis or an elevated baseline tryptase. There was considerable variability in the omalizumab dosing protocol used, as well as variability in the target maintenance venom immunotherapy dose, ranging from a standard 100 microgram maintenance dose to high maintenance doses of 200 to 300 micrograms of venom. While many of these patients successfully achieved unsupported VIT maintenance, by which I mean omalizumab successfully suppressed allergic side effects and was then able to be successfully withdrawn with ongoing tolerance of VIT, some patients were not able to tolerate VIT even with omalizumab, or redeveloped allergic side effects to VIT on omalizumab withdrawal. This suggests omalizumab does not actually assist VIT with inducing mechanisms of immune tolerance. The largest study of omalizumab in VIT is a recent Australian study, which was a retrospective chart review of honeybee venom immunotherapy patients at a single hospital. In this study of 354 patients, 16% of patients had severe allergic reactions to VIT, and 10% or 36 patients in total received omalizumab to manage these severe allergic reactions. 35 of these 36 patients had severe allergic reactions during the build-up dosing phase of venom immunotherapy, while one patient was on maintenance venom immunotherapy when they developed their first severe allergic reaction. Predictors for omalizumab requirement were severe sting anaphylaxis, asthma, and an elevated baseline tryptase. This figure is a graphical representation of the omalizumab requiring patients, mapped to their baseline tryptase, the VIT protocol used, the VIT maintenance dose, the omalizumab dose, and the therapeutic outcome. Patients with systemic mastocytosis are starred. The omalizumab protocol varied somewhat, but in general, a loading dose of 300 milligrams was given at 2 weeks before VIT, and then 150 milligrams was continued fortnightly until VIT maintenance dose was reached, with the majority of patients updosed by a semi-rush protocol. 22 or 63% of patients achieved unsupported maintenance, i.e. they continued to tolerate VIT after withdrawal of omalizumab. Excluding 5 patients who declined or lacked access to ongoing omalizumab, this success rate increased to 73%. 12 patients developed severe allergic reactions on withdrawal of omalizumab. 3 of these patients subsequently tolerated maintenance venom immunotherapy when it was built up to a higher maintenance dose of 150 or 200 micrograms. All 3 patients known to have systemic mastocytosis tolerated unsupported maintenance. In summary, clonal mast cell disorders are common in patients with Hymenoptera venom allergy and act to increase the frequency and severity of sting reactions in these patients. Hereditary alpha-tryptophanemia accounts for most cases of elevated baseline tryptase and may be an independent risk factor for severe sting reactions. Patients presenting with Hymenoptera venom allergy can be assessed for risk of clonal mast cell disorders using a combination of clinical features of the sting reaction, patient sex, physical examination, baseline tryptase, plus or minus tryptase genotyping, and peripheral blood KIT PD816V testing if it's available. For patients assessed as being at risk of clonal mast cell disorders, a bone marrow biopsy is usually necessary for definitive diagnosis, but pathology reporting errors are common and biopsies should be reported at centres of excellence. VIT may be less effective or have high rates of treatment-related systemic reactions in patients with clonal mast cell disorders. In these patients, omalizumab premedication and building up to a higher maintenance dose may be beneficial. There are still unanswered questions. For example, while hereditary alpha-tryptophanemia appears to impact the severity of venom reactions, further studies are still needed to determine what treatment implications hereditary alpha-tryptophanemia may have in the natural history of patients who need venom immunotherapy. There is also a question of how to manage patients with Hymenoptera venom allergy and mast cell disorders in whom VIT is unsuccessful or not readily accessible. Can these patients be managed with mast cell-directed therapies instead, for example? Omalizumab is known to benefit symptoms related to mast cell-mediated release in mastocytosis patients, and there are case reports of patients being protected against sting anaphylaxis on omalizumab alone following withdrawal of venom immunotherapy. And we have a patient like this ourselves at the Royal Hobart Hospital. In 2023, the KIT P816V selective tyrosine kinase avapritinib was approved to treat indolent systemic mastocytosis, a disease subtype frequently linked to Hymenoptera venom allergy, but it is unclear whether this or similar tyrosine kinase inhibitors in development for mastocytosis might prevent or reduce the severity of Hymenoptera venom-triggered anaphylaxis. Bruton's tyrosine kinase inhibitors, which would be confused with KIT inhibitors, are also being investigated for its potential in managing mastocytosis and anaphylaxis due to BTK's role in mast cell signaling and activation. So these are just some of the future directions for research. I hope you found this a useful overview on the topic. While I couldn't present this live, I would be happy to receive any questions by email. I'm also happy to share the slides of this talk with the references for all the figures and tables used. Thank you.